Thank you. Again, I just wanted to thank Dr. Salon and the organizing committee for inviting me. I also, there's been great talks this morning. I also just wanted to echo a few things that Dr. Salon mentioned in his talk. I remember when I sat through my boot camp with a similar talk, and it was very beautiful and inspiring what you said to the trainees. It really serves as a template or a framework for how training should be. So thank you for that. Also wanted to share two things as well, two statements from my own training that was sort of put in our workroom. And one of those statements was patient, service, self. And these are sort of the priorities when you're in training. You always want to take care of patients, followed by the service, and the service could be, patients of your colleagues, your co-residents or your co-trainees and your attendings, and then of course taking care of yourself. And the second statement that was always written in our call room was, for the war to be easy, the training must be hard. So you always want to make sure, as during all courses of your training, to do as much as you can in order for when you are a neurosurgeon outside of training, for your job to be easier. So I just wanted to share that with you. A lot of the things that I'm about to talk about have been previously mentioned. So hopefully this talk will be a little shorter, and I may skip some slides. But I was asked to talk about neurological and the neurotrauma assessment. So the essential parts of the neurological exam are six: the mental status, language, cranial nerves, the motor system, sensory system, and reflexes. And we'll go through each one of these parts. So the mental status can be subdivided into the level of consciousness. People have described this as being alert, somnolent, obtunded, and so on. Orientation questions, attention span, mood and affect, which can be described in those stated ways, and disorders of thinking and perception. So you always want to be aware of these things as you go on and sort of focus your neurological exam based on where you are, whether it's in the trauma bay, whether you're in clinic or seeing patients elsewhere. Language, the previous speaker touched upon this as well, can be subdivided into fluency, comprehension, naming, repetition. As we talked about, Broca's aphasia is more expressive. So you aren't fluent, the patient can comprehend, but a repetition is difficult. And each of these have a localization point as well. There can be Wernicke's aphasia, which is a sensory aphasia, transcortical motor, where fluency is affected, but comprehension and repetition is intact in the SMA area, and then as well as conductive aphasia, which has a maintained fluency, comprehension, but no repetition. Moving on to cranial nerves. This is a picture of the skull base with those nerves, and we'll go through each of them very briefly. The olfactory nerve, cranial nerve 1. Indications for carrying this test are usually associated with patients you probably see in clinic, that aren't so acute, but frontal headaches, possibly seizures, which might be due to an olfactory groove meningioma. The smell test is conducted using a non-noxious stimulus, such as soap or coffee, testing each nostril individually. Moving on to the optic nerve, cranial nerve 2, a test for visual acuity, visual fields, and pupillary reaction to light. Again, one of the key things of this is trying to figure out if there's an afferent pupillary defect using the swinging flashlight test. Vision can be affected based on a lesion, can be complete blindness of one eye, all the way to a homonymous hemianopsia, depending on where in the visual pathway the lesion is. In terms of eye movements, cranial nerve 3, 4, and 6 are the oculomotor, trochlear, and the abducens nerve, respectively. They're involved in pupillary constriction and dilation, as well as eye movements and eyelid elevation. Dysfunction can lead to pupillary inequality, including anisocoria, diplopia, or ptosis. In concert, the purpose of these are for the extraocular muscles to work together for conjugate gaze and convergence. And so this is a picture describing some abnormal pupils. You can see in number 2, pretectal area lesions there can lead to fixed pupils with hippus. Of course, with herniation, you can see pupillary dilation that's fixed. Midbrain lesions can cause fixed mid-position pupils. Pons lesions can cause pinpoint pupils. It's also important to look at the differential for abnormal pupil sizes. Mydriasis or pupillary dilation can be caused by disorders of the third nerve, and these can have different etiologies as well, including diabetes, aneurysm, herniation, and tumor. Drugs can also affect pupillary size, including scopolamine, atropine, and cocaine. Systemic drugs that have anticholinergic effects, antihistamines, and amphetamines can lead to pupillary changes as well. Meiosis or smaller pupils can be caused by Horner syndrome, the so-called Argyll-Robertson syndrome as a result of syphilis or diabetes, pontine lesions and hemorrhages, as well as medications. Moving on to the trigeminal nerve, obviously there's 3 branches. Both motor and sensory divisions of the trigeminal nerve should be tested. The presence of wasting of the temporalis muscle suggests involvement of the motor root. The jaw deviation on opening, you can also see jaw deviation on opening of the mouth as well. The muscles of mastication should be palpated because they are innervated by the trigeminal nerve. And of course, they're the 3 sensory divisions of the trigeminal nerve. The facial nerve, the function of that includes the muscles of facial expression and taste in the anterior 2/3 of the tongue. You can ask the patient to smile to assess the strength of the lower face, wrinkle their eyebrows, or squeeze their eyes tightly. The lacrimal and salivary glands are also innervated by the parasympathetic fibers carried by the 7th nerve. The 8th nerve, or the vestibular auditory nerve, you can test for that by rubbing fingers grossly to see if there is equal hearing on both sides. In patients who are comatose, the doll's eye maneuver, or moving the head side to side and observing the movements relative to the globe, is important. You'll see that comatose patients with an intact midbrain and pons, the eyes will deviate toward the opposite side of head turning, as you can see on the left side of the image. And caloric testing can also be used to confirm the presence or absence of brainstem function. Cranial nerves 9 and 10, the glossopharyngeal and vagus nerves, are usually tested together. They involve innervation of the gag reflex. Hoarseness can be caused by vagus nerve dysfunction and occurs within lesions of the nucleus ambiguus as well. Unilateral deviation of the uvula can be caused by the 10th nerve, as can be seen in this photo on the right. Moving on to the spinal accessory nerve. This supplies the ipsilateral sternocleidomastoid and the trapezius muscles. Weakness of head turning to the opposite side can be as a result of spinal accessory nerve injury. You should also observe for muscle atrophy, palpate the muscle against resistance. Hemiparesis may be associated with weakness of the shoulder shrug and weakness of turning the face, as we talked about. Finally, the 12th cranial nerve, the hypoglossal nerve, contains motor fibers to the ipsilateral tongue. Damage to this nerve leads to the tongue atrophy, weakness, and fasciculations. The tongue protrudes towards the side of the lesion, and we used to use the phrase licks the side of the lesion in order to remember how that presents. And this can lead to dysphagia, dysarthria, and difficulty with dyspnea as well. These are just some shortcuts in terms of the motor exam and figuring out what nerve roots can be affected and what functions they have. More important ones include C5 and C6, which deal with biceps, elbow flexion, and wrist extensions, and so on. Motor exam, it's important to know how to grade this motor strength exam. It's very helpful in terms of communicating the patient's clinical status to your consultants, senior residents. The main differentiation here is motor strength of 3 if it's the movement can be done with or without gravity eliminated. Sensory exam, key points on the sensory exam. T4 is usually the nipple, T10 is the umbilicus, and moving on to the lower extremities, L5, the dorsal part of the foot, S1 is behind the leg. Reflexes, biceps tendon is innervated or localized to the C5-6, the musculocutaneous nerve, and leads to elbow flexion. Brachioradialis is localized to C6 and leads to elbow flexion. Triceps tendon is C6 and 7, which leads to elbow extension. Patellar tendon reflex is L3-4, which leads to knee extension. And the Achilles tendon is S1 to S2, the tibial nerve, which leads to plantar flexion of the foot. Again, there are grading systems for the deep tendon reflex. 2+ is normal. 3 and 4 leads to hyperactive reflexes, with clonus being 4. And that's also important. Clonus, Babinski, and Hoffman signs can be signs of myelopathy, and the bulbar cavernosus reflex is also important in evaluating patients with spinal injuries. Radiculopathy, sort of touched on this in the prior talks as well, but in terms of seeing patients in clinic or in the ER, the emergency room, if they have specific symptoms, you can use those to localize what level the lesion or injury is. We already touched upon some of the clinical syndromes in the previous talk, so I'll skip this. Moving on to neurotrauma assessment. This is also important for us as neurosurgeons to deal with head trauma and spine injuries. It's important to see the overall picture of the patient in terms of the initial survey, which includes airway, breathing, and circulation. So when you enter into the trauma bay, I always tell our trainees to take a second to observe what's going on, what drips are present, what are the vital signs, who's in the room, what's the alertness of the patient. That also helps in terms of determining what the next steps in evaluation and assessment are. But focusing on blood pressure, oxygenation, motor strength, and symmetry are all important in evaluating a trauma patient. Some pearls in terms of improving outcomes in these patients. We always have to be wary of hypotension because there's an increased risk of mortality. Similarly with hypoxia, and a combination of both can lead to drastic implications in terms of clinical outcomes. So these are also important things to note. Hypotension usually is rarely attributable to head injury, except in terminal stages and dysfunction of the brainstem, obviously blood loss, particularly in other parts of the body, and then cardiovascular collapse can occur, especially in pediatric patients where the blood volume is less compared to adults. We talked a little bit about neurogenic and spinal shock, so I'm going to forego this in the interest of time. Initial survey, again, evidence of injury. We want to evaluate each part of the neurological system through a concentrated way, which includes the head, the spine, eyes, tympanic membranes, and then any evidence of CSF leak. And so when you look at patients, the raccoon's eyes or battle sign can be indications of skull-based fractures. So you have to be aware of CSF leak, especially with hemotympanum, as we mentioned, rhinorrhea and otorrhea, facial fractures and periorbital edema and proptosis. Also, craniocervical auscultation can lead to diagnosis of bruits and fistulas, so that's also important to take into account. We all know about the Glasgow-Coma scale. Again, it's also important to know this really by heart, because when you're communicating the patient's examination, it's very helpful to your seniors and to the attendings or consultants, so that a plan can be made appropriately. In summary, you really have to combine the clinical cues and the mechanism with the radiological findings on physical exam. History is critical, as we mentioned. The exam is used to localize, and the radiology is used to confirm. Nowadays, a lot of times, at least in the US, we get images so fast that the art of the physical exam is lost. And so it's very important to focus on this and have a rhythm in terms of how you see patients. And to add to that, serial assessment, especially in patients who you're trying to assess what to do next, is important, and to document these focal findings. So learn it all, learn how to divide it up. As I mentioned, the focus exam, never skimp important features, and document those findings so that people who continue to take care of patients know if there have been any changes. As Dr. Salman mentioned, these slides were taken from the Society of Neurological Surgeons. I put their website there because they have a whole series of lectures for neurosurgical boot camp that I think are important, and maybe you guys can use as reference as well. Thank you.